C-spine passive accessory motion. So we have PA-CVP, posterior anterior central, PA-UVP, posterior anterior unilateral vertebral pressure, and then we have TVP, transverse vertebral pressure, plus we also can do a longitudinal cephalad in this instance. In order to perform these, it's quite important to be able to find the correct vertebra. Don't be hard on yourself in worrying that, don't forget, for one, you can't feel C1, so you'll go from the occipital protuberance straight onto then C2. C2 stands out nice and large, so occiput C2. After that, C3 and C4 tend to play a little trick on you. So you kind of have C2 sticking up like that, and then C3 sometimes sits down here and C4 sits in there. So then what you don't have is a very clear differentiation between the two, or even you just can't feel it because it's hidden away. So they can be a little bit complex. Equally, C4 can swap over and you can't feel C3. And or you can sometimes have vertebrae that are then bifid, so it looks like a snake's tongue. So you have the two elements to it. And then in some people, it should have been bifid, but it was only one aspect of it grew very clearly. So then it feels like the vertebra is off to one side, when in fact all it is there's only one part of the spinous process and there should have been two. The more you feel this region, the better you'll get. So do make sure that you experience it as much as you can. Be careful, ensure that you're looking at the safety of both the patient and of yourself, and that they've been cleared for anything that might limit you from performing any of these techniques or even doing the assessment itself. So for doing a PA-CVP, we're going to work out our occiput down to C2. Nice and clear on this patient here, that is my C2. So I'm going to do a PA-CVP on C2 because it's really probably the best start in terms of when you're first really experiencing these techniques and when you're practicing. So when we're trying to do that, probably the easiest way is to try and have your thumbs around in this direction. Depends really upon the amount of force that you need to apply as to whether this technique will work for you. If it does, then great. If it doesn't, then we've got adjustments. I'm just going to lower this bed slightly. Because we want our force to be going slightly upwards towards the eye, because then it's following the line of the facets. So I then place my shoulders over the top, hands are either side but not pressing on, and then my pressure comes down and through from my elbows. So I'm not bobbing my body. Okay, that is my pressure of a PA-CVP on C2. Take one hand away, you can still see it, don't do it this way, but at least then you can still see my pressure. So there's a lot less pressure here versus the lumbar spine, hence you can do it this way without putting too much force through your thumbs. Equally, if you find that really ineffective, or you've got some people have got really bendy interphalangeal joints, you may want to then feel for the vertebra and apply the pressure with the other hand over the top. Just bear in mind, this is very powerful. Don't go shoving and pushing really hard against people's C-spine. You should be backing off in terms of your pressure compared to what you're doing in, say, the lumbar spine or even the thoracic spine. So please bear that in mind. When you're coming into C3, C4, the chances are you're not going to be able to differentiate very clearly between the two. If you flex their neck, then that tends to open them up a little bit, so it can make it slightly easier. But if you count and go, hang on a minute, this isn't quite right, then assume that one of them has hidden out the way. Certainly if they have disruptions in the C3, C4 region, the accuracy of having to be exactly on the precise spinous process in that area perhaps isn't as important as just applying the pressure that may alleviate some of the pain. So bear that in mind. Then of course we can work our way down into the lower C-spine, same process. If you find that you're having to lean too far, then of course come round to the side. I like to then swap my hand over, because then with this hand here I can apply that pressure up a lot easier in this way. So my thumb is on there, that is on there. Or we can again place our thumbs together, get my body over the top, and then apply the pressure up towards the eyes. PA-UVP is the same thing, but all we're going to do is come off to the side. So for instance, if I was on C2, then I need to come out to the side. It's not very far off, there isn't really a very clear transverse process, so we tend to be just working onto the lamina. So we therefore come out to the side, and then I've got really broad thumbs, so I find it quite difficult to apply my double pressure here. So I might try and squeeze in my thumbs together and apply most of the pressure through one and some of the pressure through the other. If you find that the patient is particularly tensing up, this one isn't, but if you have lots of tension coming from the neck, then of course you may need to work on soft tissue before you can do these techniques. Transverse vertebral pressure, bed needs to be up nice and high. Again, you're always pushing away from you in terms of performing the technique. You need to be able to feel the spinous process. C2 nice and easy. C3, C4, really, really difficult. So what you tend to do is if you're working in that region, you would almost write in your notes that you worked within the C3, C4, maybe into C5 for a transverse, because it's they're so small. How anyone would be able to work on just one of those vertebrae, I don't know. You'd need hands that were half the size of mine, I should think. So we find the vertebra, the spinous process, and we try to come off down into the side. You can apply your thumbs together, which of course makes it even broader, which to a certain extent can make it less accurate. And then we're applying our pressure across. Or, similar to what we've done before, we can just put our thumb feeling for the spinous, working down into the side, gently just dropping it down, and then using our key grip onto our thumb to then apply the pressure across. Again, please note, you do not apply the same level of forces to the neck as you do to the lumbar spine. Much, much less. Finally, for longitudinals, we're going to ask the patient to turn over onto their back. And to perform these, they're going to have, you can do it with the head completely off the edge of the bed, but it's not always necessary. Because of the position of the camera, I'm not going to do that. But if you're having difficulty with your handling, then of course you can. We can do it in two different positions. One is the straight position just here, and the other is with the head and neck slightly flexed. So if we're looking at doing it just straight down here, we will work the region of C2 to C4. If we flex it to around 30 degrees, we're working from C4 down to C7. That's the emphasis though. At no point must you consider that if you do it straight, you won't pull on C7, for instance, because of course you will. You're transferring forces down the spine. This will even pick up into upper thoracic. So let's do it in a neutral position. The hand comes underneath this way. That shape there, I then put just below the occiput, so kind of in line with around C2, so that I can then clamp up and in onto the head, sitting just in there, so I can pull the head upwards. Come up into there. Okay. So now I've got the support. Okay. The head is off the table. My other hand is going to come onto the chin. So I'm supporting around the side of the head and the chin, dropping myself into a position where I can then pull towards me. My back leg is also in a position, it's back there, so that as I'm pulling, if they say it hurts, and of course when I say they should be tapping the bed or fiddling with their fingers or something, not speaking and not shaking their head, then to release the pressure I can push from my back leg. Don't be in a position where both legs are forward and you just lean backwards. It's very dangerous. So have your back leg back. So here and here, in this position, elbows in nice and tight to your body, and then I can use the strength of my legs to apply the longitudinal. So here we go. Watching their eyes at all times, making sure that there's no issues there, and they know that if they need to, they can tap the bed or shake their hands or something. And if I say, are you okay, I want a thumbs up from them. Okay? We can do a sustained pressure like this, and then also we can oscillate. If we need to, we can do a more flex position, and then of course we're pulling more upwards or sustained. Cannot stress enough, if you're taking on any of these techniques that we've been doing in C-spine, lumbar spine, etc., you need to have been trained and on an appropriate course so that you can do them. No one should take this on unless they have been appropriately trained and assessed.